Hi, I'm Kimberly Frederick, Senior Vice President of Mission. On behalf of the Crohn's and Colitis Foundation of America, welcome everyone, and thank you for attending today's program, which is supported by an unrestricted educational grant by Centocor Ortho Biotech. This program is our first webcast series targeted to healthcare professionals, and we are very excited to offer this program as part of our commitment to furthering professional IBD education year-round. The content covered in today's program stems from the Crohn's and Colitis Foundation's 2010 Annual Advances in IBD Conference, which is the leading conference on Crohn's disease and ulcerative colitis. The 2011 conference will be held December 1st through December 4th in Hollywood, Florida. For more information regarding the conference and registration, visit www.advancesinibd.com. As a reminder, this webinar is the first in a series of 3 webinars. Be sure to register for the remaining 2 webinars that will be held April 12th and April 26th at 6 p.m. Eastern Standard Time. To register, click on the Upcoming Presentations tab in your webinar series profile and select the programs you wish to register for. And now it's my pleasure to introduce Dr. William Tremaine from the Mayo Clinic, who will be moderating our program.
Good evening, and thank you, Kim. Welcome to tonight's webcast, Challenges in the Clinical Management of IBD Patients, with our faculty, Drs. Ed Loftus, Gill Melmed, and Sandy Chem. My name is Bill Tremaine, and I will be your moderator tonight. Following each presentation, we'll open up the program to a short question and answer session. You can submit your question then or at any time during the program via the web by typing in Ask a Question in the text box and clicking the button to submit. We will take as many questions as we can as time allows. You can collect your continued education credit after completing the evaluation form at the end of the program. If you should need technical assistance, please type your inquiry into the tech support box on the left side of your screen and click the Send button. If you're disconnected from the webcast, you can log on again using the instructions provided to you for accessing this presentation. If you cannot log back on with these instructions, please call 877-843-9272 and ask for assistance from one of our technical support representatives. It's now my pleasure to turn this webcast over to our first speaker, Dr. Ed Loftus from the Mayo Clinic, who will speak about understanding the natural history of ulcerative colitis and Crohn's disease and implications for choice of therapy. Ed, the floor is yours.
Thanks, Bill. Thanks for allowing me the opportunity to speak tonight. One of the challenges in managing patients with ulcerative colitis and Crohn's disease is that there's such a wide spectrum of disease severity, and what we'd like to do is target our therapies to the appropriate patients. In other words, use our stronger therapies for patients with more aggressive disease and use perhaps safer therapies for patients that have milder forms of disease. And this has been a continuous challenge. Are there ways that we can predict early on in a patient's disease course if they have an aggressive disease course or a milder course? And so we have to go to natural history studies to answer that question. And I'm going to show you a few slides tonight that are examples of those studies. So the first slide comes from a study we performed in Olmsted County, Minnesota, which is home of Rochester Mayo Clinic. And we looked at a group of over 300 patients who were diagnosed with UC between 1970 and 2004. And what we found was that over time, about 30% of those patients required colectomy. So the challenge is, how can we identify those patients in advance and perhaps target our therapies to those patients to alter the natural history of disease? So what we did is we went back and we looked at clinical or demographic features that could be identified early on in their disease course, in other words, the first 90 days, and then see if those were associated with time to colectomy. And what we found was that male gender and diagnosis after 1990 were associated with a higher risk of colectomy. And this is one example of a study we did. When we looked at the endpoint of hospitalization in the same group of patients, we found that extensive disease early need for steroids, and early hospitalization were all significant predictors of time to subsequent hospitalization. Now, Crohn's disease is a little bit different. The dynamic is different because along the way you can develop intestinal complications that might be irreversibly altering the course of disease. So in other words, if you develop a stricture which requires a resection, or you develop an internal fistula or an abscess which might require drainage or a resection, then you're altering the history of disease because those patients they're at risk for bile salt diarrhea, bacterial overgrowth, and some of their symptoms may no longer be from pure Crohn's inflammation. And we know that over the course of time, in this study performed by Jacques Cohn and colleagues in Paris, most patients start out with inflammatory disease, but over time they're more likely to develop either penetrating complications like an internal fistula or an abscess, or stricturing complications. We did a similar study in Olmsted County, Minnesota, looking at, again, patients diagnosed between 1970 and 2004. And what we found was that right off the bat, 19% of patients present with a penetrating or a stricturing complication, 81% present with an inflammatory phenotype. When you follow those inflammatory patients out over time, what we found was that after about 20 years, 40% of them had gone on to develop either a stricture, fistula, or abscess. And when I'm talking about fistula, I'm not talking about perianal fistula, we're talking about internal fistulas. Then, when we regressed back to see which factors early on in diagnosis could predict time to intestinal complication, we found that the following were most significant: ileal extent, ileocolonic extent, upper GI involvement, and perianal fistula in the first 3 months after diagnosis was of borderline significance. So again, these are just examples of such studies. When you put all of these studies together and studies from other groups, we find that the following seem to be predictors for more advanced disease: early diagnosis for Crohn's disease, meaning under the age of 40, ileal or ileocolonic extent, fistulizing disease at diagnosis, early need for corticosteroids, possibly ASCA and other serologies, and possibly certain genetic factors. When we look at ulcerative colitis, the factors that seem to stand out are extensive colitis, male gender, early need for steroids, and early hospitalization. So now perhaps we can start using these factors to tailor our therapy. We do have circumstantial evidence from several trials of biologics that by intervening with an anti-TNF agent, we can reduce the onset of major endpoints such as surgery. In the example of this study, an infliximab study, where the rate of surgery was cut in half, and in the example for hospitalizations, adalimumab in Crohn's disease, again, a more than halfway reduction in risk of hospitalization over the course of the study. So we have this circumstantial evidence that we can alter some of these major endpoints. Now what we need to do is have longer studies to show that we truly are altering the natural history of disease. And in Crohn's disease, it's imperative that if you were really going to truly alter, you have to impact early, because if you wait too long, you're going to have strictures, penetrating complications occur, and then again, some of the symptoms may be driven by things that aren't due to the Crohn's inflammation. And I'm going to finally leave you with this slide, which tells us a lot. It's from the SONIC trial, and it shows us that combination therapy was more effective than azathioprine alone, but also this is looking at the subset of patients who had a positive CRP and also had lesions on endoscopy. So in other words, you're not going to treat Crohn's disease if the symptoms are not due to Crohn's disease. So make sure your patients have biologic evidence of inflammation before you start using a biologic. So to summarize, we can use these natural history studies to identify which factors are associated with a more severe disease course. Then we can consider more aggressive therapy, combination therapy, in patients with certain disease factors such as male gender, extensive colitis, early steroids, early hospitalization. In Crohn's disease, ileal or ileocolonic extent or fistula diagnosis, early need for steroids. And then finally, when you make a major treatment decision, make sure that the symptoms are actually due to biologic inflammation and not due to other factors such as irritable bowel, celiac, bacterial overgrowth, and the like. Thanks.
Well, thanks, Ed, for your presentation. We're now going to revisit the questions that were asked during the webinar survey. So, Ed, if you would go through this first question, please.
Sure. Ashley is a 22-year-old woman who was recently diagnosed with Crohn's disease of the ileum. She also presented with a perianal fistula. She required a tapering course of prednisone within the first 3 months of diagnosis. How would you characterize her potential for developing an internal fistula, abscess, or stricture over the next 10 years? A, low, B, medium, C, high, D, cannot be characterized. And I think the correct answer here is C, high. We've listed some of the risk factors for time to intestinal complication, and that includes ileal disease, early need for steroids, and early fistula. She meets all three of those criteria. So the answer is C.
Okay. I would encourage you to send your questions in. We'd like to get your participation, and we're looking forward to seeing questions. And I want to start out the questions section, if we can, with a question about ulcerative colitis. You mentioned that historically about 1/3 of patients with ulcerative colitis end up going to colectomy. And we would all hope that with our efforts with therapy that we're going to change that. Is there any evidence so far that with immune suppressants or with biologics that we are changing that colectomy rate?
Well, there's a sub-analysis from the Act 1 and Act 2 trials that would suggest that we can reduce the rate of colectomy over the course of those one-year studies. So we probably can reduce the rate of a major outcome like surgery. It would be nicer to see that built in prospectively into protocols and also for longer periods of time to see that we truly are making a difference in that surgical rate.
Okay. With regard to Crohn's disease, I'd like to address this question to both you and Sandy to get both the adult and pediatric perspective. I think, Ed, you mentioned that one risk factor for aggressive disease was upper GI involvement. I suspect there's more upper GI disease in the peds patients, but I wonder, does upper GI involvement prompt you to be more aggressive with early therapy? And if you see someone with gastroduodenal Crohn's disease, would you treat that person differently than someone presenting with ileal disease?
Well, I think in an adult patient, I would. I think that portends that they have more aggressive disease and they have systemic disease, and I would be less optimistic that some of the local therapies would be beneficial.
And I have to agree, and I think we're going to touch on this a little bit during my talk, but the concern is, at least in pediatrics, not only the need for earlier intervention and more aggressive medication, but for us, we have the unique issues with growth and development. And we know as a fact that it is really crucial that we catch these kids before they reach puberty. So not only do we need to be aggressive about medical therapy, therapies that we know will induce mucosal healing, but at the same time very adjunctively think of their nutritional status as well.
Great. And I want to just kind of get your thoughts. I don't know if there's any data on this, but you mentioned a certain subset of patients present with strictures.
That's right.
Do you think those patients had inflammatory disease prior to the onset of the strictures, or is that a different phenotype? Is there a group that only gets strictures?
That's an excellent question. I think the answer is we don't know. My own personal bias is that at least a subset of those stricturing patients seem to have almost a different pathogenesis. They will not develop inflammatory symptoms until they start developing obstructive symptoms again, and it seems like they just go right to stricturing disease. These are often the patients that have jejunal mid-small bowel disease. Those are tough patients sometimes to monitor, and I think in those cases you sometimes have to be aggressive with cross-sectional imaging like CT or MR enterography to understand what's going on with those patients.
Okay. So any comments, Gill, about the natural history or presentation so far?
Well, I think this speaks to the need that we have in IBD in general to be researching and developing and looking for ways to stratify our patients in order to be able to predict who are those patients that are going to end up with more severe disease that we should be intervening upon more aggressively.
Okay, well, we've reached the end of this question and answer session for Ed's presentation. Ed, we'd like to thank you. Do you have any closing remarks about your presentation?
Well, I just think that, it would be easy if all of our therapies were, completely 100 efficacious and safe, and then we probably wouldn't be having this conversation. So we're always balancing the potential benefit and the potential risk, and this is just one of the challenges, and I think it's one of the art, the art of medicine to sort these things out.
Okay, well, thanks, Ed. I would now like to introduce Dr. Gill Melmed from Cedars-Sinai Medical Center, who will be talking about vaccination issues in IBD. Gill, the floor is yours.
Thank you, Bill. It's a pleasure to be here and participate in this program. So we're going to be talking about this last topic that Ed just touched on, the risks of treatment with inflammatory bowel disease, some of which are largely preventable, and specifically the prevention of infections in patients with inflammatory bowel disease. So we know that many patients with IBD are going to require treatment with immunosuppressive therapy, with immunomodulators and biologics and steroids. And we also know that infections are the most common significant adverse event amongst immunosuppressed patients with inflammatory bowel disease. Dr. Loftus and others have published on the risk of serious infection that increases with the number of immunosuppressive therapies that our patients are taking, oftentimes 2 or 3 at a time. But the key is that many preventions are preventable with routine preventive immunizations. In 2004, IBD-specific vaccination guidelines were published, and this is a summary of what they highlighted. Number 1 is that IBD itself, even though it's an immune-mediated condition, should not impact vaccine response. IBD is rare before the age of 5, so most children have already gotten their routine vaccinations prior to their diagnosis. At the time of diagnosis, it's important to evaluate patients for their route. The biggest impact in adults with regards to preventive immunizations probably has to do with influenza vaccine and pneumococcal vaccine, especially amongst our immunosuppressed patients. Non-live vaccines are generally considered safe and should be given regardless of immunosuppression, but in general, and we'll spend a little time talking more in detail about this, to avoid live virus vaccines if patients are immunosuppressed. We performed a survey at our institution of close to 200 patients with regards to their vaccination history and what risk they might have for vaccine-preventable illnesses. And a key point to remember here is that over 80% of our patients had reported a visit with their primary care provider within the previous 12 months. We asked them about risk for influenza and pneumococcal vaccine, and that risk primarily being a history of immune suppressive medications, and over 80% of our patients met that criteria. However, when it came to asking them if you had received a flu shot within the past year, about 20% of them reported receiving a flu shot, and less than 10% had ever received a pneumococcal vaccine. About 40% of our patients had risk factors for hepatitis B, yet a minority had received the vaccine. We considered everyone at risk for tetanus, yet less than half could recall a tetanus vaccine within the prior 10 years. And finally, just to mention this important vaccine here is varicella. We asked patients if they could recall a history of chickenpox or varicella vaccine ever, and a significant minority reported never having had one or the other. And then when we checked their serologic status, a significant proportion were truly naive to varicella. And I highlight this point because varicella can be extremely morbid in the adult immunocompromised patient, yet is a live virus vaccine that is considered contraindicated in patients who are immunosuppressed. Our findings have also been shown and demonstrated in other healthcare settings in other countries, as well as in Europe and Australia. So this is a ubiquitous problem. Well, when it comes to actually giving vaccines to our patients who are immunosuppressed, do they respond appropriately? We assess patients' response to pneumococcal vaccination in patients with inflammatory bowel disease, and we recruited 3 different groups of individuals. In the blue, you can see those individuals with inflammatory bowel disease who were receiving anti-TNF medication together with an immunomodulator. In the orange are the patients with IBD who are only on 5 aminosalicylates, considered not immunosuppressive. And in yellow are healthy control populations. And what you can see is we evaluated response to pneumococcal vaccine for 5 of the 23 antigens that are in this vaccine. And the blue bars are smaller than the yellow and the orange. That's the bottom line, that patients who are immunosuppressed with both an anti-TNF and an immunomodulator have a significantly blunted response to each of these pneumococcal antigens relative to their non-immunosuppressed control counterparts. I'd like to highlight some of the vaccination issues with regards to other vaccines in this short scenario. An 18-year-old woman with ileal Crohn's disease who is on immunosuppressive therapy. She's on adalimumab, an anti-TNF drug, and going away to college. So this is your visit before she's going away to college. What vaccinations should we be thinking about in this young woman? We've already discussed that influenza and pneumococcal vaccine should be given pretty much to everyone, particularly in individuals who are on immunosuppressive therapy. An additional point to highlight is that pneumococcal vaccine is not necessarily recommended for everybody who is not on immunosuppressive therapy, but because of our findings that patients who are immunosuppressed may have a blunted response, and it's unpredictable when patients might require immunosuppression, we would generally consider pneumococcal vaccine indicated in all patients. With regards to this young woman going away to college, something to think about might be the meningococcal vaccine. Meningococcus is available as a polysaccharide vaccine, which is considered safe in immunocompromised individuals. And the college environment, particularly college dormitories, is considered an at-risk environment for transmission of meningococcus. This is a young woman for whom the human papillomavirus vaccine, the HPV vaccine, is indicated and licensed. She may have already received it, but it's worth checking. Did she receive her HPV vaccination? We know from data published in several different cohorts that women with inflammatory bowel disease, particularly if on immunosuppressive therapy, may be at increased risk for abnormal pap smears. Hepatitis B is something that she's probably gotten already because it's generally required. However, hepatitis B status should generally be checked and assessed prior to initiation of an anti-TNF. And finally, coming back to varicella, if in doubt, check the varicella titer. Even if this individual is already on immunosuppressive therapy and you're not going to vaccinate if naive, it still would be a good idea to know the varicella status so that if an exposure takes place, you can deal with it knowing that your patient is at risk. Some additional considerations when going away to college or in a close environment or for household contacts when it comes to giving vaccinations has to do predominantly with live vaccines. We've already mentioned the meningococcus, which is not a live vaccine but should be considered in the environment of a college dormitory. But there are other environments where one would need to think about live virus vaccines in the setting of household contacts. In general, live virus vaccines are considered safe for household contacts of immunosuppressed individuals, with the exception of the live intranasal influenza vaccine. That's available as a killed vaccine, as a non-live option, and there is the possibility of influenza transmission by shedding after the virus has been administered for a few days afterwards. With regards to travel, many endemic areas for hepatitis A require hepatitis A vaccination, and it is considered safe in patients who are immunosuppressed. However, one important point to mention with regards to travel vaccination has to do with the yellow fever vaccine. The yellow fever vaccine is a live virus vaccine and is absolutely contraindicated in individuals who are immunosuppressed. At the same time, certain endemic areas for yellow fever may actually require yellow fever vaccination in order to admit an individual to the country or to the area, unless there is medical justification for not vaccinating. CDC actually does suggest that such individuals who can't get the vaccine and are at risk for the infection consider not going to these endemic areas because of the severity of a potential reaction to receiving the vaccine in an immunocompromised individual. And just a word about the zoster vaccine. It is a live virus vaccine that's generally considered indicated for any individual over the age of 60. And recent recommendations actually allow the possibility for considering this vaccine in patients who are immunocompromised with the setting of low-dose immunosuppression. And those low doses can be looked up with regards to prednisone and immunomodulators. However, with the caveat and caution not to administer the vaccine in patients who are on biologic therapy. So to summarize, vaccination against influenza and pneumonia should be considered in everyone with inflammatory bowel disease. Immunosuppression is unpredictable, and may blunt vaccine response, so consider vaccines early in the patient's disease course. Specifically, address varicella vaccine risk before patient undergoes immunosuppression. And finally, pay attention to these special considerations, special issues which may pertain to travel, college, and household contacts, which may require consultation with additional specialists on a case-by-case basis. Thank you.
Thanks, Gill, for your presentation. We're going to revisit the question that you were asked before this webinar. And Gill, take us through this one, please.
Sure. Which of the following live virus vaccines should be avoided in household contacts of immunosuppressed individuals? Number 1, measles, mumps, rubella. Number 2, varicella vaccine. Number 3, rotavirus. Number 4, intranasal influenza vaccine. And number 5, I'm not sure. I believe the answer here is number 4. And I would just point out that vaccines 1, 2, and 3 are generally part of the routine childhood vaccines, and this might come up in a situation where the mother has IBD and is immunosuppressed and she wants to know about vaccinating her children. These are generally considered appropriate to administer to her children even though they live in the same household, with the caveat of avoiding diapers after the rotavirus vaccine and washing hands carefully and avoiding an individual who develops a rash after varicella vaccine. But number 4, the intranasal influenza vaccine, there is a non-live alternative, and that should be administered.
Okay, thanks. If you want to ask a question, make sure you take advantage of this opportunity. Type your question in the open area under Ask a Question in that box, and then click the button to submit it. So our first question, Gill, is from Regina Schmidt, who asks, how long after vaccinations are given do you have to wait to initiate therapy with immune modulators?
So this is a question that does come up quite a bit. With regards to non-live vaccines, which can be administered in patients who are already on immune modulators, there shouldn't be an issue at all with regards to when to start a new immunomodulator. But with regards to the live virus vaccine, so a situation might be where an individual is naive to varicella and you want to administer the varicella vaccine prior to initiating a biologic, for example. I've heard different recommendations. Publications have suggested waiting 6 to 12 weeks after vaccination in order to initiate safely an immune suppressive medication, but sometimes people need to start their medication sooner, and that really needs to be taken on a case-by-case basis.
Okay, well, thanks. I'm curious. I've always frustrated with the patients I have who are healthcare workers who even don't get flu shots. How do you get your patients to take flu shots? What's the trick?
I don't have any magic. It's a question of education. And I think this whole topic in general is education, educating the providers, educating ourselves, the individuals that are prescribing these therapies, that we talk about risk, but we can also address with patients how we can prevent risk. And these are completely preventable or largely preventable risks associated with the therapies that we're prescribing our patients. So I think presenting it in that context may at least give the patient more insight into why we are recommending these vaccines.
On the other side of the coin, it seems like I have a number of older patients who want the shingles vaccine, and I'm reluctant to give it to them because they're on immune suppressants. Is it worthwhile checking antibody titers?
As far as I understand, checking antibody titers doesn't really portend with the risk of developing shingles. I'm not sure that checking varicella titers really gives insight into that, and it's not generally recommended in the general non-immunosuppressed population. There are specific guidelines with regards to which immunosuppressants and what doses of immunosuppressants are appropriate for actually receiving the shingles vaccine. And they have to do with low doses, prednisone less than 20 milligrams, 6-MP or azathioprine at doses that are considered low, but our patients may actually be on for which it would actually be considered appropriate. But anti-TNF drugs, for example, would be an absolute reason not to consider the shingles vaccine in these patients.
Okay. We have a question from Sarah Mordhorst. We're going to stretch you a little bit on this one, Gill. This is not exactly about vaccines, but it's about biologics. We're talking about infections. This is a question about using Helminth worms to help reduce the severity of symptoms, especially in ulcerative colitis. Any comments about worm therapy for IBD?
Worm therapy for IBD is an interesting concept. The part of it has to do with the epidemiology of IBD, that IBD is less prevalent in developing nations and maybe they're exposed to some antigen that protects them, like worms, which are ubiquitous in certain parts of the world that are not here. And maybe administering these antigens or worms may actually stimulate part of the immune system that may help fight or prevent or treat IBD. And there is some early data from early trials, I think, that suggests that this may be a reasonable approach that may help some individuals. As far as prime time, I certainly don't recommend it for my patients, and I'd be interested in hearing from others how they handle the situation with their patients as it comes up.
It certainly is available over the internet. Sandy, any comments about worm therapy in pediatric patients?
We always get the gamut, especially with pediatrics, with the families being so concerned about toxicities. And as I say, I tell the families I like them to be educated. We talk about sort of the immune basis as well, where we're trying to skew that immune response from a Th1. That's a type of immune response that causes inflammation in folks who have Crohn's versus more the allergic type of phenomena to sort of balance that out. So there's some basis for it, and there's some pilot or preliminary data, but until it gets approved, I tell families that I'm really hesitant. And I also have sort of the fallback that I'd like to see what our adult colleagues find before we proceed. So I'm really lucky there.
Ed, any comment on Helminths?
No, I mean, I agree with all these comments, and there is this, interesting corollary between when we cleaned up Helminths in the water supply back in the 30s, 40s, 50s, and then that was coincidence with the rise of IBD. And if you recall, back in the about 10 years ago, our colleagues at the University of Iowa did many of those early studies with Helminth eggs, and it looked promising. It would be nice to see more studies before we go recommend it. I mean, many of us are aware of reports in the lay press now about people administering other Helminth eggs or even hookworm eggs, and I get nervous about that. It's done in a very uncontrolled fashion, and what's the safety, what's the toxicity of that? So I'm concerned.
Gill, we have a question from Dina Stewart who asks, does the H1N1 vaccine follow the same protocols as the influenza vaccine in immunosuppressed patients?
Yes, H1N1 is now, at least as of 2010, was included as part of the routine influenza vaccination, and it's generally considered part of the package. So it is indicated. It's something that I recommend to my patients. They're now getting it anyways. When you recommend a flu shot, you're getting H1N1.
Okay. All right. So thanks, Gill. Any final comments to us about vaccinations?
I would just say think about it early. When you first meet a patient, when you first establish a diagnosis, we often have a little more time with the patients, so that might be a situation to have it part of your plan to be thinking and addressing these issues.
Okay, it's now my pleasure to introduce our final speaker of the evening, Dr. Sandy Chem from University of North Carolina at Chapel Hill. Sandy, the floor is yours.
Thank you very much, Bill. So I get the pleasure of ending this very fun session that we've had today. And I'm going to talk to you all about growth and development issues in the pediatric population with the focus on enteral therapy, which was one of the hot topics at our Advances in IBD meeting in December of 2010. So my goal today is to review some best practices related to growth and development in the pediatric population, and also to talk about the utilization and appropriate implementation of enteral nutrition in pediatric patients, which could hopefully be extrapolated to our adult patients as well. So I always like to start with this slide and remind people that children with IBD are not small adults. And so we know that it is less common in pediatrics, but as the group out at Kaiser Permanente has shown, the incidence and prevalence is really increasing in the pediatric population. We know that children who do get Crohn's disease or ulcerative colitis often have a much more severe course, even though the GI symptoms or gastrointestinal symptoms they have are pretty much the same as what you would see in their adult counterparts. We know that with Crohn's disease, there's greater progression to more of the severe forms of disease that Dr. Loftus had mentioned earlier. We also know that kids with ulcerative colitis often present more with a pan-colitis type of picture rather than more isolated in specific segments. And finally, unlike the adult IBD patients, we really have to deal with issues of growth and development, and hence the subject of my talk today. So Neera Gupta and colleagues had done a collaborative study a few years back through a CCFA and CDHNF funded Pediatric IBD collaborative. And what they looked at were almost 1,000 kids and looked at different criteria, including those who had growth failure, which they defined as being less than 5th percentile on their weight for age or growth velocities, and found that at least 10% did have some manifestation of growth failure. It was greater in boys than girls. And as I'm going to talk about some statistics, this number may seem a little bit low, but part of the reason some of the other studies may have cited higher numbers is because of different definitions. And so I just want to show you, this is a copy of a growth curve for our non-pediatric colleagues. We monitor this very closely, looking at both height and weight. And as you can tell, the growth percentiles in this particular child were really very low, below the 5th percentile, which just isn't acceptable. And once the child was diagnosed and put on appropriate therapy, you can see that both the growth and weight parameters did improve significantly. So growth issues, growth impairment or failure are very common in IBD, much more so in Crohn's disease than ulcerative colitis, but even children with ulcerative colitis can develop issues with growth. So we know that depending on what studies you look at the time of diagnosis, that kids will have had decreased height percentiles, decreased height velocity, anywhere from 1/3 to almost 80%. And by the way, just for the viewers, I don't have the references here on the slide, but for the printouts that you make, all the references will be on those slides, so you don't have to worry about that. The big issue is that we know that height at maturity is compromised even in children who are post-diagnosed if the appropriate therapies aren't implemented. So we always say that growth window is crucial. And so for, again, our non-pediatric folks out there, when we talk about growth issues, we're talking about pre versus post-puberty. And again, we have a very narrow window to be able to capture these kids in terms of targeting therapy effectively. And I always like to say that growth is a really good marker for disease activity, in addition to the things that we commonly ask for, the GI symptoms, abdominal pain, cramping, diarrhea, anorexia, etc. So there's several factors that can affect growth, and the biggest thing that we focus on is the disease severity and the degree of inflammation. So from an inflammatory or immune-mediated side, certainly we know certain inflammatory cytokines, such as interleukin-6 and TNF, definitely can affect growth. And so this is something that should resonate when we talk about therapies that are developed that take care of inflammation, could also really have an impact on growth as well. Certainly corticosteroid therapy is something that can really impact these kids in terms of growth, as well as skeletal health and other issues. Inadequate oral intake, and this goes with adults as well. If you feel horrible with stomach pain or anorexia or nausea, you just don't feel like eating, but by doing that, though, you're not getting enough calories, protein, and some of your nutrients. Certainly with diarrhea, malabsorption, nutrient loss, loss of calories. And so I always say that if you had to pinpoint some sort of take-home points in terms of what you need to look at, not only do you need to identify the disease and treat it, but most importantly, again, I know I'm going to sound like a broken record, but you really need to think about intervening quickly. And we always say it's not just the time that you intervene, so pre-puberty, but even the interval from onset of symptoms to diagnosis. And the reality for a lot of kids, since people don't see Crohn's disease and ulcerative colitis as children's diseases, we find that some of these kids can go upwards of a few years before they're diagnosed. And I always say disease location is another crucial issue to focus on, especially small intestinal or jejunal. And as others have alluded, it's the folks, especially with mid-jejunal or small intestinal disease, often that are some of the toughest to monitor. And these are also the kids who are at greater risk for things like growth impairment. So we always say that sometimes timing of surgery is really crucial. And Davies et al. Back in the 1990s looked at a really nice study and found that regardless of localization of disease, if you could intervene with surgery in these kids while they were still prepubertal, you could actually make a 2 to 3-fold impact on their growth velocity. So just a brief note on pubertal delay. Basically the same factors that affect growth will affect puberty as well. And again, the nutrition, the cytokines, etc. The big thing I always say, the reason that this is something that we feel very passionately about as pediatricians, we're not just talking about the health, which is important. We're not talking about nutrition growth, but the psychological impact. If you can only imagine a teenager is already going through with a disease and on top of it has issues that they will definitely have to struggle with. So overall principles in managing growth failure: assess and optimize your nutrition. Look at the calories, but not just the calories, but try to determine which minerals and vitamins are deficient. Reassess disease activity. Doesn't matter if they don't tell you they're not having the GI symptoms. Remembering that, again, growth failure is a good marker of disease activity. Consult with your endocrinologist if needed. And above all, avoid corticosteroids. I preach this over and over again. So I'm going to talk about enteral nutrition a little bit now in the final few slides of my talk, since that was, again, a hot topic this year in terms of how that can be used both for growth and for treatment. Certainly biologics and immunomodulators used judiciously are important. We know that infliximab, in fact, was shown in the collaborative REACH study to actually help with growth velocity. In smaller studies, methotrexate has also been shown to help with growth velocity. Thiopurines, not so much, but still do work very well. And finally, surgery used judiciously. So in terms of enteral nutritional therapy, again, we know that there can be anywhere from 50 to 75% therapeutic efficacy. There have been about 5 small prospective studies encompassing about 167 patients studied that looked at remission rates, the effect on growth and mucosal healing, and found that the patients who received enteral therapy did have not necessarily better immediate remission, but better maintenance of remission, definitely had a more positive effect on growth, because in fact steroids had a negative impact, and better mucosal healing. So the question becomes what type of formula you use, elemental versus just your regular polymeric formulas. Different folks that looked at content of fat, glutamine, elemental versus polymeric, and the bottom line is it doesn't make a significant impact. The important things that we know is that it's improved remission when you have 100% or a higher amount of your total calories with the enteral nutrition versus smaller needs. So there are 2 phases to think of, induction and a maintenance. So the induction therapy component, I'm going to share with you utilizing the protocols by our colleagues, Drs. Baldessano and group at the Children's Hospital of Philadelphia, where they took a formula, gave about 90% of the total caloric needs, 7 days a week for induction for 8 to 12 weeks, and then maintenance for 5 days, and found that at 8 weeks, at least 87 to 90% of the kids had at least some response, with the subsequent maintenance of remission in about 2/3 when these children were followed out. The big thing is there are no adverse events, although not everybody necessarily liked some of the things about being on enteral therapy, like the tube. They actually did well otherwise. So how does enteral therapy work? And you know, this is very promising, but just as we want to know how medications work, the future directions of how we're going to study this look at potential mechanisms of action. Different ongoing studies will address some of this, including different compositions, the nutrients. Is it because you decrease the antigenic load, meaning less protein going to the intestinal tract? Are you sort of affecting the gut intestinal, the microflora, the bacteria in your gut? Other trials that will be really helpful for us include looking at how you induce versus maintain remission. So some of the ongoing studies at sort of the folks in the United States who are at the forefront of enteral nutrition therapy are looking at some of these questions with a really interesting focus on the effect of enteral nutrition on your intestinal microbiome or the bacteria in your gut. And that's a really interesting area, not just for pediatrics, but for adults as well, which you will be hearing a lot about in the press if you haven't already. So I think as a community, we really want to focus our future investigations in some of these questions that we've brought up, really focusing again on what types of enteral nutrition, how we use it to induce and maintain remission in our patients. Thank you.
Sandy, thanks. We're going to revisit the question that you were asked during the pre-webinar. And Sandy, if you can go through this question for us, please.
So this is one of those questions that look like something you'd put on the SAT. So it's always those negative questions. What is not true in pediatric IBD? So number one is that earlier pediatric onset Crohn's disease is more aggressive than adult onset disease. The second answer is there is a higher incidence of pancolitis at the time of diagnosis in pediatric versus adult onset ulcerative colitis. The third option was gastrointestinal manifestations of Crohn's disease differ in kids with Crohn's disease versus adults. The fourth option was growth failure and puberty delay are seen in children with Crohn's disease in UC, and the final one is I'm not sure. So as I said before, it would be the gastrointestinal manifestations of Crohn's disease are the same. It's just that the severity with the Crohn's disease, meaning quicker progression to things like stricturing and penetrating type of disease, quicker progression to surgery, and in the case of ulcerative colitis, more kids present with a more fulminant or pancolitis type of picture versus something, for instance, like left-sided or proctitis. And again, as I said, yes, it is more aggressive. And then the second question is the medications below have been shown to improve growth velocity in pediatric Crohn's disease, except which of the following? Again, one of those. So the first one is methotrexate. The second one is infliximab. The third one is budesonide, and the fourth one is I'm not sure. And as I mentioned before, both infliximab and methotrexate have been shown to improve growth velocity. Budesonide has not. While it doesn't have the systemic corticosteroid effects that things like prednisone and solumetrol do, it still could have a negative effect on growth.
Okay, well, Sandy, you'll be pleased to know that none of our audience was not sure. They all had a definite opinion.
Absolutely.
So you did a good job with educating. Great. So thanks for your presentation. If you in the audience have questions for Sandy or other of our speakers, please ask them now by typing your question into the area on the Ask a Question box again, and then click on that to submit. So, Sandy, you've prompted a number of questions. This, I want to start with you and then go to Ed and Gill for more discussion. This is from Walter Goldstein, who asked, what is the view on the history of enteral nutrition on IBD in adult patients and children? I want to start with you. Do you always have to give enteral nutrition down a tube with kids? Or how do you decide who gets a nasal gastric tube and who takes it orally?
So first of all, I will say that if someone could take it orally, more kudos to them. Just because of palatability, it's just not going to be a practical option. One could argue that passing a nasogastric tube may for some people also not be practical, but it depends on how you approach it. And I really defer to Dr. Baldessano's group in Philadelphia. They are just very matter-of-fact about it. They have very good teaching videos. So we try to do the same, where we have someone actually instruct the family how to use them, and basically just give the positive reinforcement and give this as an option. I did have one child who drank it. The mother's comment was that she's going to drink it because we don't want the medications. But generally, I feel that that sort of sets up an antagonistic relationship, not so much with the parent, but with the child.
Ed, give us your thoughts on enteral therapy in adults with Crohn's disease.
Well, you know, it's fascinating. It seems like we're, everything goes in cycles. And, when I was in training, we talked about enteral nutrition. We did it once in a while, but not that often. And I think it just raises the issue, do we have to revisit this as an adjunctive therapy? Right. And I think the other thing, it just, to me, sort of more from an epidemiologic point of view, it raises the issue, and we've heard this, and it's controversial, but is there something in the Western diet that is there a dietary antigen? Is it a direct antigenic stimulation, or is it through modification of our microbiome? But there's something about the Western diet, maybe highly processed foods, that seems to bring on IBD. And again, with little data, more and more I'm telling my patients, get back to basics, eat fresh food, less processed food, home-cooked food, and just eat a balanced, common-sense diet.
And I have to agree with that, and I do exactly the same thing. Luckily, we have some phenomenal scientists who are looking at the intestinal microbiome right now to see, and I think preliminary data shows that there are alterations in the bacteria in your GI tract depending on what your diet is, if it's a westernized diet versus a more natural diet. But I think before we just run out and make changes, I think we need to see what happens. But I think this does tell us that we truly are what we eat, and that there really is a role, at the very least, adjunctively, for some sort of nutritional modification as time goes.
I want to get back to diet therapy. There's some questions, but Gill, let's hear from the West Coast in terms of enteral therapy. Is there? We've heard about Western diets. Let's go all the way west to California. What about enteral therapy?
As Ed mentioned, I mean, I've read about it, I've heard about it, I've talked about it, but I haven't actually done it. Recently, a patient asked me if he could try enteral therapy, and I said, why not? But at the same time, it's just not something that we generally consider mainstream standard of care treatment now to help patients with inflammatory bowel disease. I think the discussion of diet is really interesting. Patients have a hard time grasping how could it be that a disease in my gut isn't caused or affected by what I eat. And as Sandy, as you described, I think we need to learn more and understand more about the various nuances about what we're ingesting and how that comes into play with the intestinal immune system.
Well, let's sort of migrate to that area, because I think all of our patients, if they aren't curious about what diet they should be on, their family or their friends are giving them lots of advice. And we sometimes see patients who are on very restricted diets because of all this advice. How do you handle that, Gill, the patient who is on a carbohydrate-free diet or a meat-free diet, or how do you approach that patient?
I typically don't have a standard diet prescription that I give my patients. I give recommendations in general terms in times of active disease without a lot of data. In times of active disease, to avoid high fiber, avoid dairy products which can stimulate diarrhea when there's already diarrhea present and rapid transit. Like Ed, I advise sticking to the basics when someone's got active disease and try to stay away from processed foods. I think there's some data that's emerging from the Far East, from Japan. There was a study that a Japanese diet may actually help people get into remission faster. But I think the jury is out with regards to evidence and data that can really help to drive our recommendations.
See any comments? Do you get pediatric patients on restrictive diets, and how do you handle the family?
Absolutely. And so I think, especially with where I practice, being in a university town, and with the added concern that families have about the toxicities, I think the families really want to do something that doesn't involve medications. And this is what I tell them, because I want this to be an open relationship. I want them to be able to tell me if they're going to do this. I'll tell them everything in moderation. You need to have a balance. I personally don't think processed foods should be mainstay of anybody's diet, so I tell them on a positive note, I'm glad that they are sort of veering towards some of these diets that emphasize less processed foods. But in children especially, where there's the increased sort of growing needs for adequate nutrition, when you put a child on too restrictive a diet, they may not be getting all the vitamins and minerals they want, and even for the families that are the most diehard, that will resonate with them. They know that their kids aren't getting the nutrients if they're not getting the calories. The second thing is a real psychological one, and I bet that you're going to run into this with the adults. Food is one of the things that some of our patients feel that they can control in their lives, unlike the hospital stays and the medication. And if you start messing with that, I'll tell you, I have kids who will do everything else, but when you start really sort of manipulating or trying to really push them to do something restricted, I think that's where it could become very antagonistic. So you need to learn how to pick your battles.
Sandy, I want to turn the tables on you a minute. We've been talking about poor nutrition and undernutrition and growth failure, but every magazine we pick up, we see the obesity crisis, which occurs in children and in adults, and unfortunately, my IBD patients don't seem to get an exemption from it. So, so what do you do with kids with IBD, or do you have obese kids with IBD, and what do you do?
Absolutely. So as part of one of our quality improvement initiatives, we actually monitor the kids who are at risk, failure, and are satisfactory, but we also monitor the kids who are overweight too. And so it's actually a fair number. So what happens with a lot of these kids, I think when they may have been at their sickest, we were pushing them so much to get the calories in that once they're better, the good news is they're better. But the slightly not so good news is that now they're taking all the extra calories, continuing to and gaining weight. I don't want to give these kids a complex because studies have clearly shown that kids and teens with Crohn's and UC have body image issues. So what I encourage, rather than dieting and losing weight, is to make healthier choices. And again, it's sort of the flip side. We don't want to be too restrictive, but then we don't want to go the opposite side and say you can eat anything and everything. And I tell them it's not because you have Crohn's or UC, it's because you're a teenager or you're a child and you need to be healthy. And I encourage exercise not only for the calorie burn, so to speak, but because of bone mineral issues, which we again know that osteopenia is also a bigger issue in folks who have IBD, especially Crohn's, whether it's kids or adults. So I try to put a positive spin, have them work with the nutritionists, and sort of cheerlead.
Ed, what about dosing? Some of our medications we dose milligram per kilo. How do you handle dosing in an obese patient?
Well, I think that's becoming an emerging issue, and some people have theorized that this might explain the differences in results in some of the anti-TNF trials with certain conditions, that the fixed dosing may not work as well in obese patients. And so I don't do this in everybody, but I subtly use that as a factor in making treatment decisions about anti-TNF therapy in larger patients.
Gill, any comments on obesity and IBD?
One comment that comes to mind is patients, actually, in addition to the presentation, I think, which we're seeing is evolving, it's no longer the undernourished, underweight individual, but oftentimes presentation with the situation of being obese or overweight may speak to different phenotypes of Crohn's disease, but a practical issue that has come up in a number of patients who are overweight when they have surgery is that, for example, ulcerative colitis patients who want an ileal pouch anal anastomosis may not be able to practically achieve that in the time of surgery because of the mesenteric fat that may have built up. And that's a real practical consideration. A couple of my patients have actually had to have a lap band in order to lose enough weight to allow them to have that operation successfully.
Sandy, we have another question for you. Kara Chappie asked about bone development for pediatric patients who have ulcerative colitis. So we haven't talked as much about nutrition, but what is bone age and what happens to bone development in pediatric patients being treated for IBD?
A lot of times we find that it's actually delayed. And so there are different things that, just talking about skeletal health in general, that can impact children, Crohn's and UC, a little bit more in Crohn's disease, but also ulcerative colitis as well, that can actually impact the bone development and sort of mineralization of bone. And one of the things will be disease not controlled. So we know that some of those inflammatory cytokines that I talked about earlier that can affect growth can also affect your bone development, and it sort of skews the balance between the osteoclast and the osteoblast that sort of work to model bone. So that's one issue. The second thing is steroids. And so even though we don't see it as much in children with UC versus Crohn's, in kids who are steroid dependent, we find that there is much bigger of an issue with bone development. When we look at bone age, the reason we look at it, especially the kids who have growth failure, we know that if there is a delayed bone age, then we have a chance, an added chance to do catch-up growth. And so when I have a child who is in growth failure who comes to me, that's one of the things that we do like to assess so that we know how much more of a window we have to see if they can actually hit their predicted sort of final adult height.
Okay, and I think that's all the time we have for questions. Sandy, thank you. And Gill and Ed, great discussion. We hope you and the audience found this webcast presentation informative. After the conclusion of tonight's webinar, please stay on the line and you will be automatically redirected to an online evaluation form. After completing that evaluation form, information regarding how to obtain continued education credit for attending this webinar will be provided. We invite you to join the next two webinars in the series. The first is Current Controversies in IBD Treatment. That's on Tuesday, April 12th at 6 p.m. Eastern. And the second is The Latest in Genetics, Risks, and Therapy Management in IBD on Tuesday, April 26th at 6 p.m. Eastern. The archived webcast for these series will be available online on May 12th. Thank you and good evening.